So we've got a few features that we want to look at for evidence of abnormality, and that applies to anywhere within the bowel. And the first one that I think people get very hung up on is thickening of the wall, because I guess we always feel comfortable if we can put calipers on it and say, well, that proves that must be abnormal. It's very reassuring. Actually, I think it's probably one of the least helpful things in a way, but I do understand when you're learning, you want something concrete to cling on rather than the more ephemeral stuff. So, people have published, as you can see over the decades, a whole bunch of different normal cats, and you'll notice that all the ranges are very slightly variable. I've put a little box around these middle two, and I've also put that into your notes so you don't have to frantically scribble any of this down. This is actually taken from the One Feline Ultrasound textbook, which I think if you guys are scanning a lot of cats is a good investment, because it does cover a lot of detail. It's a really detailed book. And it shows that mostly the bowel is around about 2 millimeters for the stomach, and you'll notice that the ranges aren't that far off. So 2 millimeters or a tiny bit above for the stomach, and then the duodenum, jejunum are again just slightly over 2 millimeters. But you might find that when you get to the ileum, particularly when you're finding the folds, if you measure at the level of the fold, it's just very slightly thicker again. So the general rule of thumb is for the majority of the small intestine, you wouldn't expect it to be above 2.5 millimeters. And then for the ileum, you just allow just a little bit extra, because it is that slightly unusual piece of bowel. It looks a bit different. The other things we would look for is that layering is present. We should always see layering. We should always see those 5 layers. Doesn't matter what piece of bowel it is. If you look closely enough in the colon, you will see 5 layers still. It's always there. So recognizing that it's present, because if it's lost, that implies a loss of the normal structure of the bowel, so some kind of infiltrative disease, and also that those layers are distributed in the way we're expecting. So the mucosa is the thickest black layer. We want to look at the echogenicity. So sometimes we'll find the mucosa, which should be black, becomes speckled or a little bit more echoic, and that's often a feature of some abnormality, although there can be a little bit of change of echogenicity associated with recent eating, so this applies more to starved patients. We want to look at the luminal content. So cats should usually be empty. A starved cat should have almost nothing in its bowel. It's what makes them so nice to scan. So if they're starved and yet their intestine is just full of fluid, that would be an indication of abnormal function of that intestine, even if structurally it looks normal. And obviously we don't want to see anything that's foreign in there. So looking for strings, looking for solid things that might be causing a degree of abnormality. The final thing I add on there is functional assessment. So one of the lovely things about ultrasound is it's a dynamic process, so we can actually look at the bowel contracting and say this is normal or abnormal. And there are published values. I've put a couple of notes of them in your notes as to what's a normal number of contractions per minute. Now these are obtained in lab cats that are habituated to having an ultrasound examination. And 2 things that will affect your motility is sedating the cat, so any kind of sedative drugs, and stress. And I honestly don't know of a cat that comes into your ultrasound clinic that isn't either very stressed or sedated. So honestly, I think they're useful, and it's helpful to be aware of the fact you can assess the functionality. But actually, I think sitting there for a minute and saying, well, the jejunum's contracted 6 times instead of 4 to 5 times, which is published, I think that is not helpful. What I tend to use the functional assessment for is this bowel is just sat there static, full of fluid. That's not normal function. Or this bowel is contracting like crazy. That is not normal function. So I have a more subjective approach to it. And we tend to see them just sat there with some of the enteritises. We tend to see them hypermotile very early in an obstructive condition. Because if you think about it, the bowel is just desperately trying to push that obstructive thing down. So it really goes crazy. So you can get some subjective assessment, and that sometimes is present even in the face of sedation. Which I think is very helpful. So altered layers, I've got 3 different conditions here. I've got a cat that has lymphoma, and these are confirmed cases. A cat that has eosinophilic enteritis, which we sort of recognise as a condition that cats are particularly prone to. It's more the histopathologists that are able to recognise this, I think, than us clinically perhaps, and IBD. And if you have a look, the appearance is very similar for all 3 of these. So the lymphoma, we've got the ileocephalic junction there. Isn't that a lovely thing? Seeing that little bit of small bowel going into the large bowel. But the thing that is most striking is this is that outer black layer, hugely thickened. You almost get the impression you can't see the other layers. The wall is almost replaced by that outer black layer. Here, IBD, same thing in cross-section. This is that outer black layer. It is overwhelming at a glance, spotting that. And then here we have eosinophilic enteritis, same thing, that overwhelming presence of that outer black layer. So 3 different conditions, all causing muscularis thickening. So ultrasound is not able to make a distinction between those 3 different conditions. Several people have looked at all of these things, and there is sometimes more expectation of seeing lymphadenopathy with lymphoma, but you can see lymphadenopathy with some of the inflammatory conditions as well. There is some thoughts that with lymphoma, maybe the muscularis thickening would be greater, and there's so much overlap between the patterns that unfortunately we can't rely on that either. In the main, if you look at a population of cats, the IBD ones will be slightly less affected than the population of cats with eosinophilic enteritis and with lymphoma. But in your individual cat, there is no way of using that data to say. So we have to use either biopsy or FNA, depending on sort of how we're approaching it. In my feeling, FNA of the bowel wall, when it's sort of normal overall thickness of 2 millimeters, I can get the needle in there, but I don't get a nice sample. So actually, if we see lymphadenopathy, that is where I would sample to see if we can make a diagnosis. And even then, sometimes the cytologists come back and say, I just don't know. And unfortunately, biopsy is often the only way to get a definitive answer in these cats.